we are going to talk about who are the integrated care systems. Well, 1st of July, I'm sure you felt it. Something seismic happened after many, many years of us talking about this. There are now ICSs, they are real, they are not STPs, they are ICSs and they are here to stay. So that was very exciting because some people on this panel have previously told you that maybe this will never happen because such have been the delays. To date, we've really focused on what the proposed form and function of those ICSs will be, but now that they're here and they're in front of us, we're actually going to have a look at some of them and try and work out, well, what are they actually doing? Who is involved in them? What's the political makeup? What's the financial situation? Just because we're really foolish and now we're recording these events, I'm also going to stick my neck out and put some predictions down for the next 12 months as well. Whose idea was that? I don't think it was mine. So let's do a quick recap of ICSs. This will be familiar to those of you who've been joining briefings over the last few months and indeed years. The 4 core aims of the ICSs set out in the most recent legislation is to improve outcomes in population health and healthcare, tackle inequalities, enhance productivity and value for money, and help the NHS support broader social and economic development, whatever that means. I think particularly those ones at the top around population health and tackling inequalities in outcomes and experience and access, I think those are the ones that are most relevant to the people who attend these events. I think these are the areas where the NHS needs you to help them to achieve those goals. In terms of the what actually is the ICS? Well, really, it's a complex governance arrangement that includes 3 big parts. It's the Integrated Care Board. This is the replacement for the clinical commissioning groups. It's bringing together organisations to do that planning and setting of the agenda about what health and care services should be available within a specific geography. They are the ones that are statutory accountable. There's the Integrated Care Partnership, which is going to sit alongside that. That's going to be a much broader group of people that might even include some of the larger voluntary sector care organisations, particularly if you've got really strong roots in a geographical area. And beneath that, you've got the Integrated Health and Care Boards. These are going to be there operating at a sort of place level below the system, working out what should be happening on the ground. There's this lovely diagram that they finally did for us and put into the legislation, which sets out exactly what that should look like. So the integrated care systems at the top, where the ICB and the ICP are sitting, and then a whole range of different integrated arrangements taking place at place level underneath. And here they are in Technicolor glory. There's 42 of them, 42 of these ICSs. It's better than the 150 plus CCGs that many of you will have been used to dealing with. So you can see them all here. I should say what we've done for your convenience, and it will come round with the slides, is for each of these we have included a slide that says exactly which organisations in terms of the local authorities and the NHS trusts are actually involved in each of these. There are some areas where those local authorities cross ICS boundaries. There are plenty of areas where NHS trusts cross multiple boundaries. So it's a little bit tricky. It's not as clean cut as this 42 on a map actually makes it look. So we'll share that information so you can work out who you're actually supposed to be talking to and save you spending many hours digging around on the internet to work out who's actually involved. Okay, so there's the progress so far. We've been doing a bit of digging to try and work out how are these ICSs getting on. We've had some discussions with client ICSs that we work with. We've looked at a survey of ICSs conducted by the NHS Confederation, and we also attended the NHS Confed Expo, lovely few days in Liverpool, to hear what they were all saying about the process. And I think from our experience, there's these 3 challenges that are emerging. There's a sequencing challenge, there's an external context challenge, and then there's a workforce challenge. I'll go through each of these in turn. So let's start with the sequencing challenge. There's a few different deadlines that the ICSs are having to work towards at the moment. The first was to get that integrated care board established by 1st of July. We can put a tick against that one. All 42 have an integrated care board. It has its membership set. After that, by the end of the year, the ICP has to draft an integrated care strategy, and then following that, the ICB has to have a separate strategy that they will conclude by March 2023. Essentially, the difference between these two strategies, the one by the ICP is to set the broad strategic agenda. These are our priorities, these are the things we want to focus on. The one in the ICB is there's a number of NHS constitutional standards and things that they have to do by law, and that is the strategy that specifically sets out how they're going to do that. The idea is that the ICB strategy should take note of the ICP agenda. It's the opportunity for the wider group of organisations to actually prioritise and set the agenda, and the ICB should then fall in behind that. The difficulty of all of this is, of course, that the ICB's got a very clear membership. It's your NHS trusts and it's your local authorities responsible for social care. The ICP is, however, much less well defined. In many cases, is still being recruited to. And however, despite all of this, the ICP strategy needs to come in first. So I think there's a real challenge with the sequencing here, that the ICP needs to get on. It's got to do some quite big thinking. It's not just got a list of tasks to do like the ICB. It's got to come up with an agenda that everybody is interested in and agrees with. Linked to this, in other places that have done this sort of thing before, such as Greater Manchester, they've tended to start at the bottom. They've started with their places. They've said, rather than saying, what does Greater Manchester need? They say, what does Bolton need? What does Bury need? What does Stockport need? And from that level, they have then worked up to create a strategy that fulfills all of those areas' needs and has a very clear delineation of this is what we're going to do at a system level and this is what we're going to do at place level. However, most places don't have the sort of 5 to 10 years of experience that, for example, Greater Manchester has developed. And some places are quite immature in terms of their governance and what they're going to be doing. So you've got these strategies that need to be created, but there's not necessarily the local place-based sort of governance and infrastructure in place for that information to feed up to the system. And also there's not necessarily the right infrastructure in place at a system level yet. So it's really, really tricky stuff actually, how you're going to make sure that the ICP rather than the ICB takes the lead. And if you don't, you're going to end up with a strategy that's very, very NHS oriented. So that's the real risk there. There's a second challenge, I think, which is the external context, and it really is one that doubles down on that first challenge. You can see here Amanda Pritchard, the new Chief Exec of NHS England. She gave her first speech to the NHS Confederation and focused on 4 things: recovery, reform, resilience and respect. 4 lovely R's there. Lovely speech it was too. And I think these are all perfectly reasonable aims, especially when you think about where the country is and where the NHS is at the moment. A lot of focus on trying to get rid of that COVID backlog of elective care. A lot of focus on workforce and things such as delayed transfers of care. I suppose what worries us a little bit is quite a lot of this is very NHS oriented. Some of this they will need social care providers and local authorities help with, but some of them, you know, actually cancer patient treatments, things like that, elective operations, how much you will be involved in supporting those people, I'm not so sure. So if this is the big agenda for the NHS at the time when they're trying to set the strategy about what their ICSs should be doing, I worry that actually it's going to be harder than usual, and it's already hard, as you all know, to try and get that social care perspective into those strategies. So there's this context challenge that I think, on top of the challenge I just mentioned around sequencing, is really tricky. And then lastly, there's this workforce challenge, and this isn't the usual workforce challenge that we talk about, which is, you know, how do you get enough staff? What are you going to do about pay challenges? I think this is about the fact that you've gone from having 150 plus CCGs and now you're down to 42 ICSs. It's an enormous reorganisation. I mean, people actually haven't really spoken about this is another top-down reorganisation of the NHS of exactly the kind we've been told again and again that we didn't want and we didn't need. But this here is exactly that. And it's not going to necessarily be the same challenge everywhere. And I suppose the reason for that is, for example, you can look at a place like Cornwall, where their ICB is going to involve what was Kerno CCG and then one big, large unitary local authority. But on the other hand, you've got places like NHS Lancashire and South Cumbria where they're going to be merging 8 CCGs. So there's an enormous difference in terms of the organisational change that's going to be taking place in some areas. I think we should expect that in the medium term there's going to be efficiencies that people are going to want to achieve there, and efficiencies, we're euphemistically talking. It's going to be people changing jobs, losing their jobs, trying to slimline that down. And I think that's all going to create this sense of churn on top of all of this. So there's some real challenges actually. Yes, the ICSs are here, yes, they exist, but actually in terms of getting them operational, they've got a whole lot to deal with. So while we don't have those integrated care strategies yet, we can have a bit of a look at who actually makes up these ICSs, who's part of them, what the political makeup is, and what the financial situation is. And we're going to have a quick look through what we know now. So I think the first thing is just to look at those ICB memberships. Each of those ICBs, as I mentioned, is going to include all the local NHS trusts as well as the local authorities with social care responsibilities. But that's a real range in terms of actually the size of the ICB. So you can see on the table there that the largest ICBs might have 18 different NHS trusts in, up to 13 local authorities. But down at the other end of the spectrum, you've got some that have got maybe 2 or 3 NHS trusts in, or just the one local authority. And I think trying to find common cause amongst 18, 13, 27 partners potentially in total is just clearly such a different challenge to what you'll be doing if there's just 4 of you around the table. I think that's one of these underappreciated things, is that actually trying to work as a system is going to be very, very different in different systems depending on the constellation of organisations that are already there. And here's just a sort of a graphic example of this. You've got number 42 on our list, NHS Somerset, you can see it's over here, and it's just the one local authority, Somerset County Council, and the 3 NHS trusts, and then NHS Cheshire and Merseyside, and I don't know why I've done this with letters because I can't tell you how many partners there are just off the top of my head there, but there are plenty, and you can see the difference in the sort of challenge that people are going to be dealing with. Just looking at this, this graph here, here's the total number of ICB partners per ICS. So you can see most are around that sort of 7 or 8, or maybe up to sort of 12 kind of line, but there are a few outliers that really do have lots and lots of partners indeed. So social care expenditure by ICS. This varies enormously when you look at the combined social care budgets across the ICSs. You see, for example, in NHS North East and Cumbria, the local authorities there combine to spend over £1.5 billion on adult and children's social care. They are an enormous ICS, it should be said, but that does give you an enormous amount of clout if you are bringing that sort of figure together. At the other end of the spectrum, you've got NHS Cornwall and the Isles of Scilly, just with the £263 million of perhaps it's not so important there because there will only be a small number of partners, and actually it's quite a sparsely populated but large geographical area. But you get the sense here of the differences in scale. And you can see it really is the full spectrum of budgets there in terms of adult social care and children's social care. I have to say it's really hard to find the data for all of the NHS trusts about what their total budgets are. So it's really hard to compare these to what's going on in the NHS. So I think we can't say with certainty having a big budget might influence your position within the ICS, but we can assume that it's easier if you have a comparatively larger budget relative to what's going on in the health services. Now, regular attendees of the briefing will recognise this. It's the financial stability tool that we use for local authorities. What we've done over the past few years is we've given each local authority a financial stability rating based on the extent to which they can meet their adult and children's services budgets and the extent to which they have spent or not their reserves. And what we've done here, and you'll see on the next slide, is to look at the ICSs and give an average score for each of those ICSs based on the scores of the individual local authorities within them. And the aim of this is to try and work out, are there some financially strong ICSs, are there some financially vulnerable ICSs? And actually I think it's quite a positive picture. I think what we see by doing this averaging is that it's a slightly tighter. We see more ICSs in that mixed positive and mixed negative space, so those that are neither sort of doing particularly well but not also disastrously, about 70% plus of them in that category. And I think what's also interesting though is there's far fewer in the poor and very poor ratings in terms of ICSs relative to the number of local authorities. So while we're not necessarily saying that we expect local authorities to start pooling their resources wholesale, this is not a prediction that local authorities that are currently struggling will have that picture resolved by being part of an ICS. What we're not seeing is that there are ICSs where there's 5, 6, 7 local authorities involved and all of them are struggling. What we're seeing is most ICSs include a mixed bag of local authorities in terms of financial performance. And you can see those ones on the right of the screen in the green box are those that are doing particularly well, and some familiar names down at the other end who are doing less well. Now, we started with politics today a little bit, but we don't normally talk about politics in terms of the NHS because actually it's all run by professionals and the leadership are professionals and not local politicians. So one of the interesting things about ICSs and bringing local authorities into the ICBs is for the first time it's going to really, in quite a serious way, bring NHS leadership into contact with local authority leadership, who are fundamentally political. We also think it's interesting because there have been moments where local authorities have tried to collaborate with their social care before. The Tri-Borough Partnership is possibly the most recent and sort of famous example of this. But the example there was of 3 previously Conservative local authorities that really worked together very, very closely. And almost as soon as one of those was not a Conservative-run administration, that all fell apart. Which makes us slightly nervous because what we're asking is not only the NHS to work with local authorities, but local authorities who aren't all of the same political persuasion to work with one another. So what we've done is we've mapped out the political persuasions of all of the ICSs, and what we've found out of the 42 ICSs, only 11 have politically homogenous leadership. So that's the other 3/4 of them nearly are ICSs where you're going to have Conservative, Labour, the small number of Liberal Democrats leading councils and trying to work together to come up with strategies that are fundamentally about ceding power to a system rather than retaining it locally. And you can see why the electoral incentives there are weak and why there might be some inbuilt vulnerabilities there. And it's going to be something really interesting to see how that works out over time. I'd also note that 20 ICSs have at least one local authority with minority or coalition leadership. I have to say, not all minority or coalition leadership within local authorities equals weak leadership or disruptive leadership, but I think it's a fair bet to say that it's more contested and more difficult, and all of these things that involve compromise and coming together to work with partners are harder to do if actually at your own, in your own organisation you can't set your own agenda. So we just want to flag this as something that might be a risk factor that's not on everybody's radar. And there are some great examples of this, for example, in Nottingham and Nottinghamshire, where there's a clear divide between a rural area with Conservative leadership and then an urban area with their Labour leadership. And these are the sorts of places where you think actually on a map it might look like they are a good sound boundary for a system, but there's many things going on that might actually mean that it's not so true. That's number 22 there is our Nottingham and Nottinghamshire. So here we go. Predictions for the next 12 months. So I think the backlog of elective care procedures and possibility of recurring waves of COVID-19 means that the NHS's health agenda is going to remain high on the ICS agenda overall. I think that's going to be a given. Even if we'd like them to focus more on public health and on other things, I don't think that's a negotiable. I think what we will see, though, is integrated care strategies vary in scope and quality and the extent to which they can deal with that health priority. And a lot of that, I think, is going to depend on who are the places that are already well set up to do it. I think it's really hard to envisage that people are going to make enormous strides over the next 6 months. So if you're Greater Manchester, maybe if you're some of the systems in the North East that have been doing this sort of stuff for a while, I think this is going to be something that you can cope with. If you're some of those places that really resisted ever doing a sustainability and transformation plan because you saw it as an imposition by the Secretary of State, well, I'm afraid those are going to be the problems that are now coming home to roost. So I think we'll see various levels of quality and scope in terms of those integrated care strategies. I imagine there's going to be a small number of ICSs that are just going to really, really struggle with their local authorities. They're going to be local authorities, potentially those who see this as some sort of privatisation agenda. There's going to be those with the sort of ideological bent that this is taking accountability away from local people. I think those that resisted the STP process and those with politically diverse leadership are the ones I would guess are going to be on that list. That might not be the case, but that would be where I'd be looking. In other areas, actually, there will probably be some good signs of growth in the system, and I think there may even be some talk about things like transferring of social care services into NHS providers. I think this is possibly where the government would like to see this sort of thing go, to take it out of political leadership at a local level. And you can already see in places like Trafford that some of this stuff has already started to take place. We've already got examples such as Slough, where they set up an independent trust to deliver their children's services. It would not surprise me if this is the sort of thing that emerges more and more over the next few months. The ICSs are a reality. That much is clear. That wasn't always clear, it has to be said. But that doesn't mean they're fully operational and that they have a clear strategy. There is still so much we don't know yet. Just like the local authorities and indeed the CCGs that you've been used to working with, the ICSs are going to be distinguished by their different size and complexity and character, and how that character influences the decision making of different ICSs is all yet to be seen. We expect there will be some development over the next 12 months, but we don't think it's going to be at the same rate and in the same way across all of the local authorities and indeed all of the ICSs.